She had 3 MRIs, 2 spinal taps, 4 neurologists, and a confirmed diagnosis of multiple sclerosis that she carried for 9 years. None of it was MS. What was actually attacking her nervous system, silently, aggressively, from the very beginning, was Sjögren's disease. And right now, today, there are millions of people sitting with an MS diagnosis, a POTS diagnosis, a fibromyalgia label, an anxiety label, when what is truly happening inside their bodies has never once been correctly identified. Here is the number that stopped me cold when I first read it. Neurological symptoms precede a Sjögren's diagnosis at a 2-to-1 ratio. That means for every 2 people whose nervous systems are being destroyed by this disease right now, the disease hasn't even been named yet. And in a landmark case series, every single patient with confirmed Sjögren's central nervous system involvement had already received a working diagnosis of multiple sclerosis before anyone identified what was really happening. Every single one. In this video, I am breaking down the 7 neurological symptoms Sjögren's uses to disguise itself, with the clinical language, the research data, and the exact questions you need to ask to stop getting missed. This video could genuinely change your care. Save it before your next appointment. If you or someone you love is dealing with symptoms that keep shifting, that never quite fit one diagnosis, and that doctors keep dismissing, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Before we go any further, let's talk about what Sjögren's actually is, because most people, including most doctors, are dramatically underestimating it. Sjögren's disease is the second most common autoimmune rheumatic disease in the world, right behind rheumatoid arthritis. In the United States alone, an estimated 3 to 4 million people have it, making it roughly as common as rheumatoid arthritis and 3 times more common than lupus. The female-to-male ratio is approximately 9-to-1, with over 85% of patients being female. It most commonly appears between the 3rd and 5th decades of life, though it can strike at any age. Here is what the medical system gets catastrophically wrong. Sjögren's is still primarily taught as a dry eyes and dry mouth disease. But the reality documented in peer-reviewed research is far more serious. Sjögren's is a systemic autoimmune disease. It attacks moisture-producing glands, yes, but it also attacks your peripheral nervous system, your autonomic nervous system, your brain, your kidneys, your lungs, and your blood vessels. A 2024 meta-analysis found that patients with Sjögren's face an 8.7 times increased risk of developing lymphoma compared to the general population. This is not a nuisance disease. This is a disease that is being missed, at scale, every single day. And the biggest place it's being missed is in the nervous system. To understand why these 7 symptoms happen, you need to understand what Sjögren's is actually doing to your nervous system. There are 3 major attack pathways. Pathway 1. The dorsal root ganglion. Deep inside your body, clustered near your spinal cord, are structures called dorsal root ganglia. These are the actual cell bodies, the command centers, of your sensory nerves. Every signal your body sends about pain, temperature, touch, and body position has to travel through these ganglia. In Sjögren's disease, the immune system sends inflammatory cells directly into these ganglia and begins destroying the nerve cell bodies themselves. This is called sensory ganglionopathy, and it was first described in association with Sjögren's in 1990. Why does this matter? Because when the cell body of a nerve is destroyed, the damage pattern is completely different from what doctors typically test for. Standard neuropathy testing is designed to detect the typical diabetic pattern neuropathy that starts in the hands and feet and moves inward symmetrically. Sjögren's ganglionopathy doesn't follow that map at all. It can appear on the face, the trunk, the upper arms, the torso. Areas that most neuropathy workups never even examine. This is why standard tests come back normal. They were never built to find this. Pathway 2. The autonomic nervous system. The autonomic nervous system handles everything you don't consciously control. Your heartbeat, your blood pressure, your digestion, your bladder, your sweating, your temperature regulation. In Sjögren's, small fiber nerve damage disrupts this entire system. According to patient survey data from the Sjögren's Foundation, 14% of Sjögren's patients report diagnosed autonomic neuropathy and 6% report a formal POTS diagnosis, though researchers believe these numbers significantly underestimate actual prevalence. One study of 40 Sjögren's patients found that 66% experienced vasomotor symptoms like erythromelalgia and hot flashes, 50% had chronic constipation, and 47% reported abnormal sweating patterns. These are not random complaints. These are a nervous system losing control. Pathway 3. The brain itself. Central nervous system involvement in Sjögren's is estimated between 2 and 25% of patients. That huge range exists precisely because most patients are never properly evaluated. According to Sjögren's Foundation patient data, approximately 80% of Sjögren's patients report cognitive dysfunction. When researchers conduct formal neuropsychological testing, they find subcortical executive dysfunction affecting processing speed, working memory, and verbal retrieval. The same cognitive domains affected by multiple sclerosis. Now, the 7 symptoms. Symptom number 1. Burning pain, tingling, or numbness that does not follow the usual map. This is the most common neurological complaint in Sjögren's and the most commonly dismissed one. Here is the critical fact that changes everything. Small fiber neuropathy has been identified as the most common peripheral neuropathy in several Sjögren's patient cohorts, affecting an estimated 59% of patients according to Sjögren's Foundation survey data. Small fiber neuropathy affects the thinnest nerve fibers in your body. The unmyelinated C fibers and thinly myelinated A delta fibers. These fibers carry pain signals and temperature signals. When they are damaged, the result is burning pain, electric shock sensations, tingling, and temperature dysregulation. Here is what most patients and many doctors do not know. A standard EMG, nerve conduction study, cannot detect small fiber neuropathy. It only measures large fiber nerve conduction. A completely normal EMG does not rule out small fiber neuropathy. In one study of 40 Sjögren's patients with small fiber neuropathy, 97.5% had abnormal laser-evoked potentials, a test for small fiber function, yet many of these patients had been told their nerve testing was normal. The burning can appear on the trunk, the face, the upper arms, or the thighs, not just the hands and feet. The only test that can definitively confirm small fiber neuropathy is a skin punch biopsy, a minimally invasive outpatient procedure that counts the density of nerve fibers in a tiny skin sample. A test called the QSART, Quantitative Pseudomotor Axon Reflex Test, can also evaluate autonomic small fiber function and is abnormal in approximately 40% of Sjögren's patients with small fiber neuropathy. The language to use at your next appointment. Say this exactly. I have burning pain that does not follow a length-dependent or stocking glove distribution. I would like to be evaluated for small fiber neuropathy with a skin punch biopsy and QSART, not just an EMG. If that burning pain sounds exactly like what you have been living with, and you have been told your nerve tests are normal, type the word burning in the comments right now. I read every single one. And I want to know how many of you have been sitting with this for years without anyone connecting it to Sjögren's. Symptom number 2. Facial numbness, tingling, or pain. This symptom is one of the most documented and one of the most universally missed neurological manifestations of Sjögren's disease. The trigeminal nerve, also called cranial nerve 5, is the largest cranial nerve in the human body. It controls sensation across the entire face. The forehead, the cheeks, the jaw, the teeth, the sinuses. It has 3 major branches. In Sjögren's, immune-mediated inflammation targeting the trigeminal ganglion produces a condition called trigeminal sensory neuropathy. This can cause facial numbness, one-sided facial pain, electric sensations across the cheek or jaw, and pain that mimics dental problems, sinus infections, or migraine variants. Here is the clinical reality. Patients with trigeminal sensory neuropathy from Sjögren's routinely receive years of unnecessary dental procedures, sinus surgeries, and headache medications before anyone considers an autoimmune origin. What makes this even more complex is that the trigeminal nerve also connects to the autonomic control of tear production and saliva. Sjögren's may attack this nerve partially because of how much autonomic traffic flows through it. The same structures the disease is targeting for dryness are supplied by branches of this nerve system. Trigeminal sensory neuropathy in Sjögren's has been documented in medical literature since the early 1980s. It is not rare. It is not subtle. It is simply not looked for. The language to use at your appointment. Say this. I have intermittent facial numbness or pain that I believe may represent trigeminal sensory neuropathy in the context of my Sjögren's disease. I would like a referral to a neuromuscular neurologist. If you have ever been told your facial pain or numbness is dental, sinus-related, or just a migraine, and nobody ever connected it to autoimmunity, type the word face in the comments. You are not alone in this. And the number of people who type that word is going to tell a story that needs to be heard. Symptom number 3. Balance problems that inner ear testing cannot explain. When people experience balance problems, the automatic clinical assumption is inner ear dysfunction. Vestibular neuritis, Meniere's disease, BPPV. The patient gets a vestibular workup. The inner ear comes back normal. The complaint is then frequently attributed to anxiety. But there is a completely different mechanism at work in Sjögren's. It is called sensory ataxia. Sensory ataxia is a disorder of proprioception. Your brain's ability to know where your body is in space without relying on vision. Proprioception signals travel through large diameter sensory neurons, whose cell bodies live in the dorsal root ganglia. When Sjögren's attacks those ganglia, this position sense signal is disrupted or destroyed. The result? You feel profoundly unsteady. You may sway when standing still. You may feel like the floor is moving under you. You may struggle to walk in the dark or navigate uneven surfaces. The key clinical test for sensory ataxia is the Romberg test. Standing with feet together and eyes closed. A patient with inner ear dysfunction typically maintains balance with eyes closed because their proprioception is intact. A patient with sensory ganglionopathy from Sjögren's will sway or fall, because closing the eyes removes the visual compensation they have been unconsciously using to substitute for absent position sense. This is a positive Romberg sign. Ataxic sensory neuropathy is one of the most characteristic neurological presentations of Sjögren's and was first formally documented in association with Sjögren's dorsal root ganglionitis in 1990. Patients with this form of neuropathy are at elevated fall risk, a critically important safety consideration especially in older patients. The language to use at your appointment. Say this. My balance problems persist even when vestibular testing is normal. I would like to be evaluated for sensory ganglionopathy with a Romberg test and formal neurological assessment. If you have struggled with balance problems and been told your inner ear is fine, and nobody went any further than that, type the word balance in the comments. This is one of the most dangerous unrecognized symptoms on this list because of the fall risk. I want to see how many people are living with this without answers. Symptom number 4. Orthostatic intolerance. The dizziness when you stand up. This symptom covers a spectrum. From mild lightheadedness when you stand up, to a racing heart upon changing positions, to near fainting or actual loss of consciousness. Let's get specific about the science. Orthostatic hypertension is defined as a drop in systolic blood pressure of at least 20 mm of mercury within 3 minutes of standing. POTS, postural orthostatic tachycardia syndrome, is defined as a heart rate increase of 30 beats per minute or more within 10 minutes of standing, in the context of symptoms. In Sjögren's, orthostatic intolerance occurs because small autonomic nerve fibers that control blood vessel constriction in the lower body are damaged. When you stand up, blood normally gets squeezed upward toward the brain by peripheral blood vessel contraction. When those small fiber nerves are damaged, the vessels fail to constrict properly, blood pools in the legs, and the brain is momentarily underperfused. The racing heart is the body's emergency response, trying to compensate by pumping faster. Here is a research finding that is almost entirely unknown in clinical practice. A published case series identified that patients with neuropathic POTS associated with autoimmune disorders, predominantly Sjögren's, had significantly elevated Mycoplasma pneumoniae antibody levels compared to the general population. Researchers proposed that this pathogen may trigger autoimmune damage to autonomic nerve fibers, providing an infectious trigger for autonomic neuropathy in Sjögren's patients. The Sjögren's Foundation reports that 6% of patients have a confirmed POTS diagnosis and 14% have a diagnosed autonomic neuropathy, but these numbers likely represent only a fraction of actual prevalence. Testing to ask for. Orthostatic vital signs measured lying, sitting, and standing, done with supervision. Tilt table testing for formal autonomic assessment. And evaluation by a neuromuscular specialist for autonomic neuropathy workup. The language to use. Say this. I experience dizziness, palpitations, or near syncope upon standing consistent with orthostatic intolerance. Given my Sjögren's diagnosis, I would like formal autonomic testing to evaluate for autonomic neuropathy. If you stand up and the world spins, or your heart starts racing, and no one has told you that your Sjögren's disease might be the reason, type the word standing in the comments. Because this is one of the most disabling symptoms on this list, and one of the most treatable once the correct diagnosis is made. Symptom number 5. Cognitive dysfunction disproportionate to your age. Let's be very clear about what brain fog in Sjögren's actually is, because it is not simply being tired. According to Sjögren's Foundation patient survey data, 80% of Sjögren's patients report cognitive dysfunction. 80%. This is not a fringe symptom. This is the dominant experience of people living with this disease. When researchers formally test Sjögren's patients using objective neuropsychological batteries, they find subcortical cognitive dysfunction affecting processing speed, working memory, executive function, and verbal retrieval. These are the same cognitive domains affected by multiple sclerosis white matter lesions, which is one primary reason Sjögren's CNS involvement has been repeatedly misclassified as MS. Here is the mechanism. The same cytokines that drive systemic Sjögren's inflammation, particularly TNF-alpha, Illinois 1, Illinois 6, and Illinois 17, can cross the blood-brain barrier and disrupt synaptic function. Anti-Rho SSA antibodies, present in roughly 60 to 70% of primary Sjögren's patients, have been detected in cerebrospinal fluid and may directly affect neuronal tissue. Sjögren's can also cause small vessel vasculitis in the brain, producing white matter lesions on MRI that look remarkably similar to MS plaques. In a landmark published series of CNS Sjögren's patients, every single patient had met diagnostic criteria for definite or probable multiple sclerosis before Sjögren's was identified. Cases have also initially been diagnosed as neurosarcoidosis, neuromyelitis optica, and in rare instances, Creutzfeldt-Jakob disease. The language to use at your appointment. Say this. I have cognitive dysfunction including processing speed slowing, executive function impairment, and word retrieval difficulty that I believe may represent central nervous system involvement in my Sjögren's disease. I would like formal neuropsychological testing and consideration of neuroimaging. If you have been sitting in a conversation and couldn't find a word that used to come easily, if your brain feels like it is processing through fog, and your doctors have called it anxiety, depression, or just aging, type the word fog in the comments. Because what is happening in your brain has a name, a mechanism, and a path toward treatment. And it starts with someone making the right connection. Symptom number 6. Unexplained migraines or persistent headaches. Migraine is the most common central nervous system symptom documented in Sjögren's disease. In published case series, migraine has been reported in approximately 47% of Sjögren's patients with central nervous system involvement. But here is what makes this clinically important beyond just the prevalence number. The mechanism of migraine in Sjögren's is not the same as standard primary migraine. In Sjögren's, migraines can arise through multiple pathways. First, cerebrovascular inflammation. Sjögren's can cause small vessel vasculitis, immune-mediated inflammation of tiny blood vessels in the brain, which disrupts cerebral blood flow and triggers migraine pain through the trigeminal system. Second, trigeminal nerve sensitization. Because Sjögren's directly inflames the trigeminal ganglion, it sensitizes the very nerve pathway that generates migraine pain. This is not coincidental. The trigeminal nerve is the central conductor of migraine pain. A disease that attacks the trigeminal ganglion is creating the biological conditions for migraine. Third, anti-phospholipid antibodies. A subset of Sjögren's patients carry anti-phospholipid antibodies, which cause a hypercoagulable state that can produce microembolic events contributing to headache. Fourth, white matter lesions. Sjögren's related small vessel changes in the brain produce subcortical white matter lesions that have been directly correlated with migraine occurrence in multiple studies. One of the most important clinical observations. Migraines in Sjögren's patients frequently respond poorly to standard migraine treatment because the root cause is never addressed. When Sjögren's disease is treated with immunomodulatory therapy, some patients experience significant reduction in migraine frequency. A Mayo Clinic study of 13,849 Sjögren's patients found that women with Sjögren's were 23 times more likely to carry a migraine diagnosis than men with the disease. The highest sex differential comorbidity in the entire dataset. The language to use at your appointment. Say this. I have a significant migraine burden that is not responding to standard treatment. Given my Sjögren's diagnosis and the documented link between Sjögren's central nervous system involvement and migraine, I would like this evaluated as a possible autoimmune mechanism rather than primary migraine. If you have migraines that feel different, harder to treat, more frequent than makes sense, coming with neurological symptoms that do not fit the typical pattern, type the word migraine in the comments. And if you have already noticed that treating your Sjögren's helped your headaches, definitely type that. That observation matters more than most doctors realize. Symptom number 7. Asymmetric or patchy sensory loss. This is the most diagnostically specific symptom on this entire list. And it is the one most likely to change the clinical picture if you describe it correctly. In nearly every common neuropathy, diabetic, alcoholic, chemotherapy-induced, the nerve damage follows a predictable pattern. It is length-dependent. It starts at the tips of the longest nerves first, the feet, then progresses inward. And it is bilateral and roughly symmetric. Both feet affected similarly, both hands affected similarly. Sjögren's ganglionopathy breaks both of those rules. Because Sjögren's attacks the dorsal root ganglion, the cell body of the sensory neuron, rather than the nerve fiber itself, the damage is non-length dependent and patchy. The immune attack does not follow anatomical nerve lengths. It follows wherever inflammatory cells have infiltrated the ganglia, which may be asymmetric, may skip segments, and may appear in distributions that make no anatomical sense to a clinician only thinking about typical neuropathy. This can look like numbness that is significantly worse on the right arm but absent in the left. A patch of burning sensation on one side of the torso. Facial involvement on one side only. Or numbness in the upper arm without any involvement of the hand. From a physician's perspective, asymmetric or patchy sensory loss that does not map onto a peripheral nerve, a dermatome, or a spinal cord level is a red flag for dorsal root ganglion pathology. It is one of the most specific examination findings for Sjögren's sensory ganglionopathy. Research has documented that patients with Sjögren's central nervous system involvement have received prior misdiagnoses including multiple sclerosis, neurosarcoidosis, temporary hemiplegia, neuromyelitis optica, epilepsy, and Creutzfeldt-Jakob disease before the correct diagnosis was established. The asymmetric sensory pattern is one of the primary findings that drove those misdiagnoses, because it can mimic MS plaques affecting one side of the spinal cord. The language to use at your appointment. Say this. My sensory symptoms are asymmetric and do not follow a dermatomal or length-dependent distribution. I believe this is consistent with dorsal root ganglionopathy. I would like a formal neurological evaluation including assessment for sensory ganglionopathy in the context of my Sjögren's disease. If your numbness or burning is worse on one side of your body, or shows up in places your doctors could not explain, type the word patchy in the comments. That pattern is one of the most specific signs of Sjögren's nerve involvement that exists. And I want every person watching this who types that word to know, you are not imagining this. The research says exactly what you are experiencing. Now here is the documented reality, stated plainly. Sjögren's is the second most common autoimmune rheumatic disease in the world and it is routinely, systematically misdiagnosed for years, sometimes decades. The misdiagnoses that appear most consistently in the literature before Sjögren's is correctly identified include multiple sclerosis, fibromyalgia, functional neurological disorder, anxiety disorder, depression, neurosarcoidosis, neuromyelitis optica, epilepsy, and in documented cases, Creutzfeldt-Jakob disease. Why does this keep happening? Because Sjögren's is still taught primarily as a glandular disease. Rheumatology training focuses on dryness. Neurology training does not routinely include Sjögren's ganglionopathy. Neither specialty is systematically looking for the overlap. Because the tests are being ordered wrong. EMG is ordered instead of skin punch biopsy. Inner ear testing is ordered instead of proprioception testing. Standard cognitive screening is ordered instead of formal neuropsychological testing. Because the antibodies do not always fit. Not all Sjögren's patients are anti-Ro SSA positive. Some patients are seronegative, meaning their blood tests are completely normal, but still have active disease confirmed on salivary gland biopsy. A negative antibody panel does not rule out Sjögren's. The 2025 Clinical Practice Guidelines from Arthritis Care and Research, the first formal guidelines ever published on peripheral nervous system involvement in Sjögren's disease, explicitly state that systematic neurological assessment should be a part of routine care. Most patients have never received one. The system is not making the connection. But you are in this room right now. And you can walk into your next appointment and make it yourself. Here are 3 actions to take this week. Action 1. Write down the clinical language for your symptoms. Do not describe your symptoms generally. Use the specific terms from this video. Small fiber neuropathy. Trigeminal sensory neuropathy. Orthostatic intolerance. Sensory ganglionopathy. Non-length dependent burning pain. Those words signal to a clinician which diagnostic pathway to pursue. Vague descriptions produce vague workups. Action 2. Ask whether a formal neurological evaluation has ever been ordered as part of your Sjögren's care. Reference the 2025 Clinical Practice Guidelines from Arthritis Care and Research by name. They recommend systematic neurological assessment for Sjögren's patients. This is the new standard of care and most patients have never received it. Action 3. Ask specifically about a skin punch biopsy for small fiber neuropathy and QSART testing. These are available at academic medical centers and specialized neuromuscular neurology clinics. They are the only tests that can confirm small fiber neuropathy, the most common peripheral nervous system complication in Sjögren's. A normal EMG is not the end of the road. It may simply mean the right test was never ordered. If you have been living with burning pain, tingling, balance problems, brain fog, migraines, or dizziness when you stand, and none of it has ever been connected to Sjögren's disease, I need you to hear this. You are not being dramatic. The research is documented. The mechanisms are understood. The misdiagnosis rates are real. The diagnostic delays are real. And the path toward getting the right care starts with the language in this video. Here is my question for you in the comments. Has any doctor, your rheumatologist, your neurologist, your primary care physician, ever connected your neurological symptoms to your Sjögren's disease? Drop your answer below. Because that answer matters for every single person who finds this video next. If this video gave you language you did not have before, save it. Bring it to your next appointment. Send it to the person who has been told their burning pain is just fibromyalgia. And if this kind of content helps you, subscribe. Because this is exactly what this channel is for. I will see you in the next one.